Good morning, and welcome back to our monthly live broadcasts at the Mount Sinai Hospital from our endovascular division. I'm your moderator for today, Dr. Raman Sharma, joined also virtually here with Dr. Alfio Caraccio, the Chief of Vascular Surgery from Lenox Hill. Welcome to have you. Very glad to have you here with us today. And of course, an absolute pleasure. And today we have changing the course a little bit today. We have in the lab today Dr. Prakash Krishnan, Vishal Kapoor, and Dr. Ajit Rao, changing the pace just a little bit. We have a very interesting case here today with a large right iliac aneurysm. Plan for an EBAR repair. Let's see what you guys are getting into here.
Yeah, well, thanks so much, Raman, and thank you, Al, for making time. I know you're super busy at work, and it really means a lot. So this is a very interesting case that we try to find different cases that have different teaching value to our endovascular colleagues. And obviously, in the multidisciplinary approach, we'd like to go ahead and talk about the different treatment options for these patients. We're a little bit late today because obviously a little bit of prep work involved with aneurysm work, as you know very well, Al. And so what we decided to do today was to approach this in an endovascular fashion. So let me first introduce our team. So to the right of the table, actually you can't see him, is Vishal Kapoor. He's always with us. He's our director of endovascular services at Mount Sinai Mount Sinai Morningside. Then to his left now, he just joined the table, is Dr. Ajit Rao, who's the director of research and I believe the fellowship too, right? Or no, just the research. Research at Mount Sinai, vascular surgery here at our hospital here at the main campus, and he's been a real stellar force in our program because he's really helped us to tackle these very complex cases. The way you used to, Al, when you were here back in the day, and so Ajit has been great with us and really he's helped us, take care of very, very complex patients. To his left is Dr. Ibrahim Ali. He's one of our endovascular fellows this year. He's actually going to be joining you, Al, in Northwell, but it's actually the main campus in North Shore once he graduates as one of the cardiology endovascular specialists out there. And then Ray Lascano is our endovascular nurse practitioner, who's always with us. Our team today is Jen Curiel, our nurse, and Elizabeth Holton, our other nurse. And of course, without Damien, we would not be able to get these cases done on time. We've got some help from industry as well. We appreciate the good folks from Gore for making time to be here, as well as Penumbra with some coils in case we need their assistance. And so without further ado, we also have Phillips with the IVUS to help us take measurements and decide whether we did a good job or not. So without further ado, Al, and Raman, I'm going to introduce the case with our fellow, and I think there's a lot of discussion points here. Just a little prep work. We've got what sheet on the left, guys?
16.
16 and 12, right? 16 and 12. We've got 8,000 units of heparin, and just letting you know everything is stable. We're going to get started. Go ahead, Ibrahim.
Yeah.
Oops. Prior.
Take a picture of the hypogastric. Make sure.
Okay.
All right, good morning.
Hypogastric?
We have a 62-year-old male here with hypertension and hyperlipidemia who initially presented to us with right leg claudication, which has pretty much slowly been progressing to minimal exertion pain or even rest pain at times. Initially, prior to him meeting us, he had ABIs done, which were 0.64 on the left and 1.0 on the, 0.64 on the right and 1.0 on the left. After that, he had an arterial duplex, which showed monophasic wave pattern in the right lower extremity, and there was concern for right iliac aneurysmal disease, which wasn't well visualized on the ultrasound. So at that outside institution, the patient underwent an MRA, which ended up finding a right common iliac aneurysm, which measured 5.6 by 4.5 in the axial dimension and 7.4 centimeters in the craniocaudal dimension. And on that MRA, they commented on a proximal normal segment of 1.5 centimeters prior to the bifurcation. And then the entire length of the distal common iliac was involved up until the bifurcation of the internal and external iliac artery. So at this point, we had decided to take him for his first angiogram and kind of just to better understand the aneurysm, understand the proximal neck, understand if there is a landing zone for us, and we were even going to consider embolization of the hypogastric if it was involved. So we started off our procedure with a runoff on the left side, which was more or less normal, and he had 3-vessel runoff below the knee. And then you could see all the way to the edge of the screen is our first abdominal shot where you get the first flash, I guess, of how large this aneurysm is, and the tortuosity in the iliacs as well as the tortuosity noticed in that proximal neck. As we went further into our angiogram, we were able to wire through it into the hypogastric and then take a better angiogram of it. And you can see that the hypogastric and external iliac pretty much come right off the end of that aneurysm and are more or less involved in that aneurysm. So at this point, we had thought that it was necessary to at least coil the hypogastric before moving further.
Well, I think over there, I think we should stop a little bit. Ajit, you were involved with us. So a couple of things we did to hear Alan Rumman. I initially thought that we had possibly enough of a neck to be able to land, a covered stent and then, coil the internal and then keep it as simple as we can. And so, do we have the IVUS? Did you load the IVUS?
No, it wasn't.
So okay, so we did an IVUS. Yeah, go ahead, Al.
I was going to ask a question. So on the initial slide, you said there was 7 centimeters of common iliac length. Is that correct?
By the MR, there was. By the MR measurement is what we had from the outside. That's what we had, but that doesn't look like 7 centimeters in the angio. And when we did the IVUS, Ajit and I interrogated the IVUS quite how can I say, vigorously to try to find a way to do this simpler. And unfortunately, we did not. Ajit, do you want to comment? I know we don't have the IVUS loaded, but
yeah, no, I think this is a good discussion point. The other thing is this is very angulated, so we actually did a center line as well. And if you do that, it's even less than 7. So, I mean, I don't feel comfortable, being able to seal there unless we have at least 10 to 15 millimeters. And we don't have that. And it's also tortuous. So
yeah. And I think
yeah, I was thinking, so
go ahead,
I wasn't thinking in terms of just isolated iliac on that side. What I was thinking is if you have enough length, yes, it will not land in that proximal part, which is normal anatomy, but is there an option for a branch graft so you can preserve that hypo, particularly because you said there's an ABI problem on that right side? Big source of collaterals may be your internal if something was to go awry, so maybe want to preserve that.
That's a good point. You want to make a comment?
Yeah, no, that was one of the things we discussed last time when we saw this film was whether to preserve the hypogastric. He wasn't a candidate for an IBE, which is typically how I like to preserve it because of the diameter of the iliac. So that was kind of the big an anatomic restriction for him. But otherwise, I think, yeah, it's a good point. If you can, in a young ambulatory patient, you should try to.
And Al, he has some sort of aneurysmal disease because he does have an SFA aneurysm as well, which I think, I mean, obviously he has aneurysmal disease, but I think it's more, as you would expect, more systemic. And what I think we have to do is deal with that. I think his ABIs are down because of the flow. I think, he does have 3-vessel runoff to the foot, if I remember right, Ibrahim, on the right side. So it's not something that I think we're concerned with in that manner. The only question, I guess, from a cardiology perspective that I think we need to discuss with you guys is, I mean, as a cardiologist, I know that a lot of people out there who are not familiar with aneurysmal disease, don't manage it as often as you guys do, would try to land a covered stent here, like a VBX, not a Gore stent, a BART stent, a BD stent, and try to exclude this. I mean, can you talk about some of the pitfalls and things like that in that decision making? One argument could be one of the cardiologists we discussed it with said, well, why can't you guys put an Amplatz or plug into the internal iliac and just exclude the aneurysm from top to bottom? I don't know whether you want to talk about it and tell us what your thoughts are, because obviously we didn't do that, but I'm just curious on what your thoughts are. Al?
So you're asking Ajit or myself? It's not a bad thought. It's just that the proximal site there looks rather short and it's somewhat of a setup for a leak or poor durability. So in a situation like this, I don't think there's enough length there. Like you said, it looks like about 1.5 centimeters, maybe at best.
Right.
And it may work temporarily, but I'm not sure long-term it's a great solution.
And what happens if they do that, Ajit? I mean, if they do put a covered stent and then they look good and then they develop a leak, does that burn bridges in the future to how you're going to deal with that leak and that the aneurysm is pressurized again, even if you coil off the hypo?
Yeah, I mean, there's a couple of considerations. Number one is you could definitely pressurize the sac if you seal distally but not proximally.
Mm-hmm.
So that could be worse because this is a very large aneurysm. You know, I think it was over 5 centimeters.
Mm-hmm.
So that's, you know, very high risk for rupture. So I'd want something durable.
Yes.
The other thing is it just makes your other repair, if you have to do something afterwards, more complex because you have to go through that iliac stent. And then there's a small chance, you know, it could actually maybe go into the aneurysm, you know, and you lose that proximal seal and your kind of stents floating in your aneurysm, which could be another challenge. So I think in terms of durability, that's kind of the main drawback.
Okay, so I think those are great points. Why don't you show the coil and then we'll talk and take it from there.
This is the coil that we use for the hypogastric 035 M-Bolt.
So this is important. I think
So
we can go back.
coil?
Yeah, exactly.
Why
That's
coils?
what.
Why not?
It's already did it. Okay.
Or then answer that's a plug. Save you some time.
That's a great question, and that's what I wanted to talk about. So, how do you guys choose between coils and plugs? And I think that's part of the reason. Obviously, the plugs are easy. My thought process here with the JIT was, Al, is that at the angulation I thought would be a pain in the ass to, pain in the butt to get into. So it was very, very difficult for the thought of you know, being able to engage this up and over. I think coming down the other side again, it's an acute angle if we go ipsilateral to come down. So we felt that coming from above and being able to actually cannulate the internal iliac from above and then dropping a bunch of coils might work. Now, could we have tracked his sheath up and over? Possibly, you know, but I just didn't feel comfortable. I don't know whether you would have done it differently, but I think Ajit and I had a long discussion about that because we obviously have the plugs here as well. We could do different things, but we did not. Can you go back and show the aneurysm and the takeoff of the internal external? So Al, would you have done it differently? Would you have done a plug? And if so, how would you size the plug? What would you do? So on and so forth.
Yeah, I probably would have tried the plug. I mean, there's no downside to giving a few minutes to try and cannulate. And what I would do is I would go into the furthest divisions with the wire, then switch up to a stiff wire, then get your sheath distally. So this way you have as much purchase as you can. And then you could put your plug distally and just drag your whole system back so you could just park it into the internal. It does save you time. If you find that you're spending a lot of time cannulating or you have to have the divisional branches, then probably just go with coils. And there's no downside to coils other than cost and time. But
So-
the plug, if you can get in there, it's quick and easy.
So the question is there any studies between patency between plug and coil that I'm not aware of any? I'm not very good with the aneurysm literature, but I just want to make sure there's any difference.
I'm not aware of any, but I will say that for plugs, I have had some that actually stay open despite plugging it, and I've had to come back and actually put coils. It's not common, of course, but it does happen. With coils, I feel like if you get a good packing of the coils, it's very likely it's going to thrombose off. So
And how do you size the plugs? I mean, that's always a question that we often get. And are all coils created equal? Al?
So in terms of the plug, I do about a 50% oversized with the understanding those tri-lobe plugs. When you're 50% oversized, they're going to elongate. You just have to make sure that the top end doesn't get obstructive to what you're doing in the main sac. So I will always pack at 50% oversized and really force them in. And in terms of coils, you know what? I try and use 035 coils because it fills up space quicker. But sometimes the 035 will have a tendency of pushing you out, in which case I'll use the 014s and 018s this way you can pack them and have less likelihood for dislodgement.
So, and then, you know, while they do the aortogram here, Al, just to show you what's going on, because we haven't seen the pictures since. I mean, it may still be open. We might have to do something else. The question here is, you know, in terms of coils, you know, are all coils created equal? I mean, do you guys prefer one coil over the other, or is it just all a cost issue that you deal with?
Come down.
Yeah, I mean, my big cutoff is whether you need something detachable or not. If you're not using detachables, I think a lot of the coils are basically the same. More of it is technique in terms of how densely you pack them. And most of the coils out there are pretty user-friendly. So if you're not using detachables, And the larger coils, I think for the most part, that seems reasonable. And then the real question is the science of oversizing them. You oversize them too much, it'll just take a straight path out rather than forming the that plug that you sort of want. So to me, it doesn't make much of a difference. We use a lot. If we're going to use the coils, generally we use Nesta coils, but I think anything will really work. It's what you're familiar with.
So that's great. So now you can see the aortogram. But let's just show you the aortogram. So these coils were done about a month ago, Al, and obviously we in preparation, we weren't sure whether this was going to be a live case or not, but turned out to be. And so now you can see here that that we have the coils have been placed, and it looks like the hypo is occluded. So now let's talk a little bit about this branch graft. And I think as cardiologists, who are the majority of people who watch our program, we do get some multidisciplinary views, but mostly it's cardiology. When do you guys decide on a branch graft? I know you talked about the angular nature of this, and whether it's appropriate for this. I mean, what is the advantage of preserving the hypogastric when the contralateral hypogastric is open? Is it only for buttocks claudication? Is it for patency? I mean, what's the thought process? Is it for erectile dysfunction? What's the thought process of trying to preserve that hypo? I know in all our meetings we go to, we have discussions on that. So I'm just curious on the vascular surgery side. Ajit, why don't you take that one?
Yeah, I think that's a good point. For me personally, I think I try to preserve the hypogastric when I can, but that depends on the patient too. If it's like a young ambulatory patient, with a good life expectancy, I think trying to improve their quality of life, prevent buttock claudication, things like that, is important. So in those cases, I'll try to preserve it with an IVE if I can. In an older patient where I'm doing maybe symptomatic AAA or something like that, I think it's less important. But I think, especially since the IBE came out, I try to use it when I can.
What about you, Al? Anything different?
No, yeah, basically I try and preserve it whenever possible, short of, predictors of failure. And when I mean failure being, it's really tortuous, or if your landing zones are not going to be amenable to a good seal anyhow, then I generally will coil in those scenarios. Otherwise, I try and preserve it just because you can never predict what happens. It is a lot more work. There's no question, embolization's quicker and easier.
The slides.
But if you preserve it, I think it's always helpful because it's hard to predict it. Now, people who are not big fans, let's say, of branch grafts will quote that some of the rates of consequences of embolization are reported to be much higher than what they really are. And I think a lot of it has to do with where you embolize, rather than a collective group. Embolizing the internal iliac origin, not really a problem. And once you start getting into all the division or branches, it's more distal than embolization. You can run into some issues in terms of the claudication or butt ischemia or rectal ischemia being a little worse. But I think it's more of a philosophy.
Got it. So let's go through the CT.
So this is the CT scan that was done in radiology and reconstructed with central and axial imaging. You can see the reconstruction all the way on the end of the screen, and you could kind of get an idea of how large the actual vessels are that we're going to have to use to seal. And they commented on a 1.5 centimeter proximal area to seal before the bifurcation. And then you can see in the central imaging that there is a good amount of landing zone proximally, but we are going to have to cover the bifurcation.
Yeah. So one thing I was saying, looking at that, it's sort of interesting. I would almost ignore. I don't know what length you have there, but I would almost ignore that origin of the iliac and just treat it as if it's just an iliac. If you have that, 5.5 centimeters of length in that common iliac where your branch could open, it may open in the sac and it won't necessarily reach the aortic bifurcation, but that doesn't mean that you can't do it with the branch. I think it really depends on that length. In other words, from right after that normal appearing common iliac origin, do you have that 5.5 cms to the hypo? Because if you do, yeah, it'll open up within the sac, not really necessarily the origin, but then you could just, finish that repair. I think it would be possible, but it depends on length. I don't know what you all have there. I just saw you had a marker catheter in your angio to see what you really have in there.
Right, and also the other question is, what do you lose by ensuring doing a bifurcated graft? I mean, this way you ensure your seal, right, and then you ensure that the longevity of this particular aneurysm repair in terms of making sure that there's no endo leak. So, what are the advantages of doing what you're saying, take versus covering the aorta and doing a bifurcated graft?
No, no, I would, maybe I misspoke. I would cover the aorta, no question. I think it's the right decision.
Okay,
And just
okay.
whether you
Yep.
whether you use a branch for that right side or not is still the question. But assuming we leave that and move on, there's no question I would do the aortic coverage.
Yeah.
And I think,
you're not
and
going
I,
to
No, no, I think that's the point for to understand for everybody, because I think you can get fooled by thinking you have a good landing zone to get a seal, and I think that seal is I don't see. I mean, obviously something we don't trust in terms of this guy who's a young gentleman with a long and healthy life ahead of him. I think even though it looks like we may be able to land it, I think we're not going to be able to get a proper seal. So you're still talking about the bifurcation of the internal external. I got it.
Correct. If you have that 5.5 centimeters, you can do it and preserve it. But moving on, once you made a decision, you embolized it. That seems like the smart thing to do. Now, I know you have representatives from Gore there, which is an interesting question.
Yep, that's what I was going to get to.
Yeah, why did you choose to use Gore in this case?
Yep, I'm going to let Ajit take that one because we went through all the graphs and we talked about the advantages and disadvantages, and obviously him being the expert in the room, made the decision, which I think is the right decision. Ajit?
Yeah, no, that's a great question. As we know, there's a lot of graphs on the market we can use. The reason that I chose Gore was for a couple of reasons. So number one, the aorta, especially by the renals, is relatively small. And so here we're using a Gore conformable. So we're using actually the 20 millimeter graft. So most of the stent grafts on the market start at like 23 for the most part. So the conformable, you actually have a 20 graft, which is good because the infrarenal aorta here measures around 15 to 16. So you don't want to oversize it too much. That was one reason. Number two, I just think it will track well through this. There's a little bit of tortuosity, not much. And then number three, was the conformability. It's kind of my preference. Usually for AAAs, I like Gore because if you have a lot of angulation, especially at the neck, this device, you can actually bend the stent graft, the proximal part, to kind of conform to the aorta. But I would say that for this one in particular, the main reason was just the size of the aorta. It's a small aorta, so I wanted a smaller graft.
So Al, for me, my question to you guys is, obviously as a cardiologist, I want to preserve my bifurcation. I want to go up and over. I know as great a graft as Gore and the other grafts are, it's something that's kind of, difficult to do. I won't say impossible. The issue here is why not use a dedicated, iliac graft like the one that's available that we can go up and over, the Endovascular graft. And what are the advantages and disadvantages of that? Because knowing that your aorta is small and you have the ability to preserve going up and over if you have to treat that aneurysm in the SFA in the future.
Yeah, it's a very good question, BK. I mean, I agree with everything Ajit said, and I would even add that if you're extending to the externals, the conformability of Gore around that bend off the iliac where it takes the turn out of the pelvis actually is very good. But your point is the only counter argument to that is that, I think there's no choice here. If you want to treat this appropriately, you have to extend to the top and do a formal aortic repair. But the endologics option in terms of preserving that up and over technique. Now people will say, oh, it's not a problem, but you do a lot of these peripheral interventions. It is a problem. It's not like if you set an endologics right on the bifurcation, the up and over approach is maintained. It's really nothing, but some of these devices up above to go over aortic bifurcation of an endograft is not so easy. With that said, there's been iterations of these endologics and the results, some people are not exactly big fans of. So I think it's worth the struggle to do something which can avoid that type of graft. And it's just my preference. Again, I think endologics would save that bifurcation and make life easier in the future. And with the new iterations, perhaps better. Some of the results for some of the older devices weren't so great.
So that's one of the things we talked about was, what's time tested, what's proven, what has the longevity that we're looking for in this particular case. I mean, obviously we all can do antegrade if we need to. We all can do pedal or radial if we need to, whatever it may be. But the idea would be that we since we're doing this percutaneously, we're not doing a cut down, so we can easily go antegrade if we need to. And I think that so that's kind of the logic that Ajit and I had in going with the Gore graft. Of course, his major thing was the conformability, like you talked about, over the flexion points or the tortuosity, I should say, which really helps. So we decided to go with the Gore one, right? So what exactly are we doing now?
So right now we have both our sheets in. So we have the 16 French on the right side, which will accommodate the main stent, the main body, the main stent. So that's the side of the aneurysm. So are we able to see the table?
Yes, please show the table, guys.
Yeah, so this is the delivery system here. And so some things I want to point out. So it has this handle here. So this is part of the deployment mechanism. And then the conformability that we've been talking about is through this. So you actually can see how you can bend the stent graft by just twisting this, and it will rotate the top of it so that way it kind of sits if you have any angulations. Now, our aortogram that we showed before, we don't really see much tortuosity, so I'm not sure I'll need it, but it's nice to have. And then the actual stent, you can see it's at the top.
Can you zoom out, guys? Can you zoom out for Dr. Rao?
Just so you can see is at the top of the delivery system.
At the top, yep. A little bit higher. Thank you.
Right here, the white part. So that's kind of the basics of this delivery system.
So for the cardiologist, we're on a Lunderquist wire, a very stiff wire up in the aorta. It's very important. Our sheath is in the aorta, just below the renals, as you can see. And we're going to try to track this through the sheath and then unsheath the graft, obviously. So very important, technical issues there. To do any of the technical points?
So actually one thing that also at this point that we think about is just where to position the limb potentially. So on the aortogram, you can see it looks like, our pigtail crosses our sheath. So it may be beneficial to cross the limbs, meaning that the left iliac limb is going to be pointed towards the screen, right? But I will, reassess that once we put it in. But the reason it matters is that handle I showed you, that is the direction of the limb. So we can kind of, we're going to keep it straight up when we go in, but we'll probably rotate it once we're in the body.
So Al, our ACT is what, 380, guys? Huh? Above 400 right now. We'll recheck it. We give extra because we're live. Just to let you know, we'll recheck it, and we're ready to go. If any other questions, Ram and Vishal, before we get started, or anybody want an IVUS or anything? I think we already did the IVUS before, but I don't think we need it now. We already got the CAT scan.
Correct.
I think we're ready to go and get this done. If you guys are okay with it. All right. Let's go.
We're gonna start advancing this through our sheath. It's all right.
Yeah.
Somebody take Flora, guys.
Yeah, I'll just have
All right, beautiful.
So the other thing that I did here was we put our sheath basically right by our renals, so that way we can just unsheath this device rather than tracking it bareback. And it looks like our wire came back, so I'm just gonna.
Through the aneurysm.
Yeah, I'm actually gonna just advance it now here carefully.
Yeah.
We always have this problem with Vishal and Karthik. But we used to.
All right, so device is
I feel
going
that
in.
you may
here.
just be doing it on purpose now. It doesn't.
I'm pulling it. I'm pulling it with it. Just screwing with Vishal. He knows I'm doing it on purpose.
So I know the end of my sheath is right at the renals, so that's where I'm gonna actually put the stent graft a little bit higher, and then we're gonna pull back our sheath here. And so,
so here, when I don't think you'll ever have a problem because you have such a normal aorta the whole length. But one of the other additions of a non-bare stent across the renals is if you have a plan and intervention in the future, whether snorkeling or modifying devices and all, not having hardware across the viscerals would help. So in this case, I don't think that'll ever be an issue because the aorta is totally normal. But something to consider. Now, G, you mentioned about the crossing and all that.
yeah.
I don't disagree, and I'm not certainly going to suggest anything in either way, but in normal aortas, I've always found uncrossing them helps because depending where it lands, it can kind of crimp the side off. What is your size of the aorta where the limb is?
Yeah, that's a good point. I think it's roughly around the same, so around 14 to 15, I want to say.
Okay. Reason being is if it's crossed over, it gets pancaked. Sometimes it's a little work getting through. When it's uncrossed, it's just a straight shot up. It's just a little easier to manage, but that's only my bias.
So Al, I want you to explain that because as you know, our audience is a mixed audience.
Yeah.
You have guys who deal with iliac
Sure, I
aneurysms but don't deal with
I moved
aorta,
it.
and
We'll take
gals.
another
So
picture.
what do you mean
Sure.
by crimped off? You're talking about an
So-
actual. You're talking about the contralateral gate here, Al. Is that what you're talking about?
Correct. That is correct. So the contralateral gate, when it opens, there's markers to help you orient it. In other words, the middle marker there, that's the long linear marker that's right above you, slightly a couple centimeters above your sheath. That's the flow divider. And then there's a contralateral gate, which Gore has as a metal ring. You want to place that somewhere that it's easy to cannulate. And when I say easy to cannulate,
so I just want to have the rep put the marker on the flow divider. Can you show the flow divider? Just draw a line for us.
Pause the run here.
Yeah.
So we're going to pause the run and then go. Yep.
This is the flow divider.
Okay.
And this is the gate.
All right. Thank you. That's fine. Can you go live on the screen, guys? Oh, we can't. Nope, you can't go live on the screen. Okay. Well. So basically, you're not going to be able to go live.
Yeah.
Okay. So this is part of our AV issue here. So basically, you see the end of the sheath, guys. The end of the sheath on the left side is going to be your gate, and the flow divider is about 1, 2, 3 markers above on the pigtail. So if you consider that 1, 2, 3, that's going to be the flow divider and the gate, and that's what they're looking at. So Al, you're saying don't actually crimp it, is what you're saying, because you're not going to need to.
correct.
Oh, there
So
it
the
is.
flow
You can see
divider
them.
the flow divider
there.
dictates
Higher.
what's that long marker dictates what side that contralateral gate is on. So right now,
Right.
contralateral gate will open on, looks like maybe the right, slightly anterior.
Yeah.
Right.
Yeah.
If it opens up at a small caliber vessel, your ipsilateral limb is 13 millimeters, let's say,
Can we get
and the
on her?
conjugate is 13, that's 26. So there's going to be a little pancaking in possibly.
We can move the screen this way.
I just want to show the screen.
Can you just rotate the screen? We're going to rotate the
Can you
screen
show
towards
the-
the camera.
Huh? Can you? There's no names on there. Can you show the screen for me?
Can you turn?
Yeah,
just
rotate
rotate the
it.
screen.
So I want
No.
them to understand.
Just
Hold on a
turn
second.
the screen this way.
Yeah, no,
Toward
that's
the camera right there.
Toward the camera.
Yeah, exactly. Keep going.
Yep,
So you
rotate
can
it.
explain it. And now they're going to
Rotate more of the camera.
Yeah, what we're trying to show here. So one of the things that we do is we mark out the renals, because obviously we're trying to deploy this right below the renal artery. The lowest renal here is the left side. And then the other important thing is to make sure our gate lands above the bifurcation. So actually, Alfie, I want you to take a look too, because it's a pretty long,
Yeah.
pretty short aortic from the renal, from the aorta to the bifurcation.
So we want to go live. We want to go live on the screen. There you go.
A little bit more.
Okay, Damien, can you pull this in front? Can you pull this in front of the patient? Pull this all the way out. Yep, and now turn it toward the patient. I mean, toward the camera.
Is that better there?
Yep, that's good. Lower the table, guys, if you can.
And they can zoom out.
Okay, zoom out for me. Yeah, can you get rid of the table picture? Can you get rid of all the equipment?
Yeah.
Perfect.
There you go. Now make zoom out for me. A little more zoom out. There you go. More zoom out.
Get the
Sorry,
whole
guys.
screen,
I
yeah.
was a director in my past life. Zoom out, please. There you go. Perfect. There you go. All right, let's go ahead, Ajit. Ajit is going to go over there and just show. You're going to have to just, without touching, obviously.
Yeah, I'll be
there
careful.
you go. There you go.
All right. So what we were talking about. So a couple things here. So number one, you can see the top of the graft are these markers right here. So that's number one that we look at. Number two, we're marking out the renal arteries. So the lowest one is the left one, which is here, which is marked out for us. You can see the right one. It doesn't light up as well just because of how the pigtail is, but that's higher up, a little bit higher.
Yeah.
So that's the other thing. But our main focus is going to be on that left renal, which we're going to have to land pretty close to it. Then if you go farther down, there's something where we say FD, so flow divider. So that's where the graft bifurcates. And then the other important part is where your contralateral limb, so in this case the left limb, is going to open up, and that's the gate, which is down here. And one of the tricky parts of this case is going to be our length, because we don't have much wiggle room here.
Yep.
If we have to stay above that bifurcation, so we're probably going to take a couple of pictures and make sure we're okay. Can we go one forward on the run? Just I want to see the iliac limbs, the iliacs a little bit better. Yeah, go back.
Go back one.
Yeah.
Because the other thing that we got to decide now is how to position the contralateral limb.
This is the shot you looked at.
Yeah, right there.
Right there.
So
One frame back. Yep,
Yeah.
that's it.
Yeah, so there you can see it pretty well. The bifurcation's right around there. So we have enough room, but it's very close. Alfio, what do you think about positioning?
Yeah, so that's what I'm saying. I don't want to bias you in any way, but the two things that Ajit, you mentioned, which is what we all look at, is with the tortuosity as well as this length, because from the top of the device to that contra gate is let's say 8 cms. If the length of the aorta is 8 cms, you're going to land right close to the bifurcation. If you're crossed, depending how you enter from that left side, the patient's left side, it may be a pain in the neck to angulate that gate. So I always, especially in a narrow aorta where it doesn't have room to fully expand, in a situation like this, I would uncross it. This way you'll be sitting right on top of your left iliac, just waiting to be entered. Because if you cross it here and it lands either a little anterior, a little posterior, it could be pinched off, and then cannulating it could eat up some time.
So Al, just a question for, again, the novices like me in this room. The issue here is you're saying uncross it and cross it, right? So you're saying in a normal aorta, don't cross it. Why would you cross it? Why would you? Obviously, I understand uncrossing it now, but why would you cross it?
So I cross it just because, and Ajit mentioned it earlier, when you look at your catheter from the contralateral side, in aortas that have aneurysm, often they're tortuous, you're looking at your catheter as a predictor of where the wire is going to go when you exchange that catheter for a wire. And if it's to the patient's right, then it's easier to just open that gate crossed, because the wire will be on that opposite side.
Right. So it's all about ease of cannulation. That's all we're talking here. There's nothing to do with
ease of cannulation in terms of access, and then ease of cannulation in terms of not having it crimped. Because if it's crimped, then you have to go through a few maneuvers to get through the crimp.
Okay. Totally understood. No, I got him. All right, so now we're ready. So I guess now we're going to uncross it as we talked about.
I want to uncross it.
Again, don't let me bias you guys. I don't want to be the one that walks down.
So you know what, Al? That's the fun in doing live cases, right?
So
we get great advice from great operators.
I want to uncross.
And especially, in these kind of cases, because there is no, secret sauce that works for everybody. We'd like to, show all different techniques. So I think here we're going to go ahead and uncross
this is anterior, no?
And then we're going to go ahead, deploy, and then take care of it. All right.
I like that.
Yep.
What do you think about that?
Well, we can't see it now.
A little too much. Okay, Sarah's yelling at me here.
So I would bring it back to where it was, a little bit more into the middle. Long marker is where your gate is.
Yeah,
right, I see it.
This is your gate.
Yeah.
You want to make sure if it's pointing this way, you're going to be coming towards
Yeah, so I'm happy with this.
Yep.
We're mostly, uncrossed, a little bit anterior, but I think this will work. Alfio, do you agree with this?
Well, you can't see it, unfortunately. We took it off. I think it should be good.
All right.
Let's take a shot.
Yeah, let's take one more shot here. Now I'm really going to focus in on the renals.
All right. So now everyone, we're going to look at the proximal landing zone where we're going to land is below the renals, obviously. So this is a very important part of the procedure. So we're going to do cranial 20 to actually look at the renals a little bit better. Again, in these kind of aneurysm cases we have a lot of involvement of ancillary people helping us because, again, they do this constantly and they know their device better than a lot of us. So I think it's important to understand the technical aspects of the device, which is why we're grateful that they took the time to be here with us to help us with this case.
So I actually go ahead.
Oh, go ahead, buddy.
Now I was going to say, so at this run here, our position's, I think, pretty good. We're a little bit above the lowest renal, the left renal.
Yep.
But again, you want to start a little bit higher because you can bring it down. And honestly, I think I almost want to encroach a little bit because we don't have much room with the gate, and I don't want to make that an issue. So I'm happy with where we are here.
Yeah, I like it.
All right.
Can I make one more suggestion?
Okay.
Can we
Always.
make the gate a little bit more
Anterior, no problem. So we're going to rotate the gate a little bit more to bring it more anterior. And then we're going to probably take another picture and deploy, make sure that our draft didn't jump.
I don't want to do anymore.
So always we take another shot here, quick shot, guys.
Yeah, I might, okay, let's take one more shot.
Yeah, just do one more shot just to make sure. So I'm one of those guys who needs multiple pictures to make sure I'm okay with where I am.
Yeah, so it's a little bit high, but we can always bring it down a little bit. So I think this is good to start.
I think that's a good thing for everybody in the room to see that how it did move. So take your time, take a picture. Obviously you can adjust it on the fly that Dr. Rao is going to do. So can you focus on his hands, guys? So I want him to teach everyone how to do this.
So the first step here, so we're in good position. So now we're going to remove this part here. So the graft will still be partially constrained, but it will open up. So yeah.
All right, so here we go. So he's a little bit of muscle, had some breakfast this morning.
Yep.
All right, breakfast is there. That's good.
So
Bring the sheath down a little bit.
Yep. You're crimped
yeah,
a little.
yeah. Sec here.
We'll move that.
All right, good,
Yeah.
beautiful. All right, so now you can see the stent is open up top, and it actually looks like we're in pretty good position. We have some parallax here, so parallax, if you look at those 3 markers on the top, you can see that they're not perfectly aligned. So we need to get a good cut of it. So we're going to do more craniocaudal. That's usually the answer.
Watch his face, yeah. Well, watch his face.
Yep. All
Yep.
right.
So as we go cranial, as we know with these large cameras, you have to be a little careful. So we're being careful of not to injure anybody. And now we're going to take a better picture.
Yeah. So that looks pretty good. So we'll take a picture here. And again, we're not committed because we can always reconstrain this, but let's see.
So that's the important part here. You know, confirming your position. Look at the renal. You're right below the renal, like you wanted it to be, right?
Yeah.
So it's a very good picture.
Yeah. So I'm really happy with where it is for the renals. Now the other thing, I want to look at that gate again, make sure that we're okay.
It looks like we're okay. Yeah, I like.
Where's the contra grade? Just point it out.
Right
Okay.
there.
Yeah, it looks okay. Replay the run.
I want to see the iliac. Yeah, let's see. I think you're okay, man.
Yeah, it's a little interior. It's going to be a little hard to cannulate that, but
Yeah, that's what I was
What do
talking about. Your position at the renal is fantastic. I think that looks great.
yeah.
And you were anterior. That's what I was saying. If you were completely on cross, it would have been sitting right over your left common. It would have been a
I
trip
agree.
shot to get in.
I agree.
So, why don't we recapture?
So can we
and do it?
recapture and rotate at this point?
Yep.
I feel like the gate looks.
No, it needs to be more left. Yeah.
Capture it.
Okay.
Yep. So I agree with that too, because I
Yeah.
think now you can see you're going to need an upward facing catheter to cannulate the gate.
Yeah. Okay.
So this is also a good for us to see.
Yeah.
So Dr. Rao is going to recapture.
Yep. So what I'm doing here is this has a mechanism here where you can actually basically collapse the graft again just by rotating it clockwise. So I'm doing that.
So just as you do that, Ajit, I just want to ask Alfio. Al, why can't you just rotate it without recapturing? You're not opposed against anything. Why not just rotate it?
Now rotate.
You know what? You probably could, but there's some drag on it. So if it has the capacity to restrain, it just makes it a little easier just because it's not opposing wall. There's less friction and less torque.
Got it.
I like that. You're
got
happy
it.
with
Grabbing.
Got it.
In a
I see what
healthy
you're
aorta
saying.
like
We'll
this,
take a test.
yeah, in a healthy aorta like this, PK doesn't make a difference. But if there's atheroma or intima, that's not the healthiest.
Yeah. Picture, right?
You definitely don't want to do that. It makes sense to me, buddy.
All right. So now we're a little high.
Now we're a little high.
So I've got to pull it back a little bit.
So which is fine. Again, it shows the nuances of these kind of techniques. I mean, obviously, it's not as easy as it looks, and that's
mark
why I
that
think
for
a
me?
Yeah, let me
multidisciplinary
stop. 1 second, I'll stop
approach
it
is
for you.
very good. And you can see here that it's clearly covering the renal, and so we're gonna pull back a little bit. Again, you recapture and then drop it down, but now you don't want to rotate the graft, because you want to keep the gate where you want it to be,
Yeah.
and then drop it.
Okay. So it's close all the way and bring it down.
Yep.
Yeah.
Someone has a sheet.
Yeah, we got the sheet.
Okay. I'm going to put a little back tension. How many times can we do this, Sarah?
No more than 3 times.
Okay. So,
Okay, let's take a picture then, Ajit.
yeah.
Yeah. Let's make sure
Looks
you're
better
okay
by the
with
one.
that.
That looks.
Well, Sarah, why is that no more than 3
Okay.
times? Is it that it breaks or something?
Yeah, we just don't want to. We want to make sure that we don't compromise the graft.
I see. I just want to make sure, because I want to make sure it's not made.
Yeah. So
I don't want to. I shouldn't say it. Alfio will text
One
me
more
later.
picture?
Say, what are you
We
talking
know,
about?
we know what you were thinking.
All right,
Don't move.
don't move, buddy.
Senor, no mueva.
Now, while you're doing that, you guys do these on the local? I hear you speaking to the patient about not moving. You don't put them
Can
to
we do
sleep?
another one?
No, Al. The whole idea is, we'd like to show this percutaneous, as we've been talking. We've done this under local anesthesia with dual pre-closes. Patient is wide awake. We're able to talk to him and see how he is. We've got, like I said, like you, great nursing here with Jen and Liz. So I think we should be okay. So
Shoot
far,
to the
so good.
sheath.
Yeah.
10 cc's full strength and
Yep.
hep saline.
10 cc's of saline.
So I'm being really particular here. I just want to see that
You know, not need that,
aortic
right?
bifurcation.
Contrast?
Make sure we're okay before I commit here.
Contrast coming. Full strength. That's it. All right, 20 cc's. You asked for 10, I give you 20.
Thank you. Ray, do you mind just holding this device so it doesn't pop back?
So we're going to look at the contralateral gate now and make sure the bifurcation is good.
Yeah.
So Al, that shows you there is no neck. You see that now?
Yeah.
I think that really shows you there is no neck.
Yeah.
It's still very, very close. What do you think, Alfio?
I mean, I prefer it on cross, but I'm not a fan of, I don't want to mess with the device. It's going to be a little bit of it shouldn't be terrible cannulating, but you're going to have to change your catheter, take that bend.
Yeah.
And I don't know, because if you twist, the top twists, but the bottom may drag, it may not necessarily twist. So
right.
Sometimes you think the whole device turns freely, but it doesn't. The top will turn and the bottom won't. So I don't know. I prefer it more, untwisted, but it's your call. But I think it would have been nice if it was over just a little bit more.
Yeah, no, I agree. But I think, less is more here at this point since we've already rotated it.
I wouldn't mess with the just make sure the renals look fine, that you didn't lose it, because that's what I was saying about the breathing. Sometimes a little breath makes the difference of the renal being covered or not covered when you deploy.
Yeah, on this run, if you look at the top, you can actually see that the renal lights up, and it looks like we're still good. So I think we're okay. Good. We're going to stay here. So next is just cannulating that contra gate.
Yep. So now you need to pull the piggy out.
Yep. So this is the other nice thing is, I haven't fully deployed it. So in theory, if we're really struggling, we could do it one more time, but we'll obviously. Yeah.
Soft angle.
Floppy glide wire.
Soft angle.
Floppy glide. All right. So this part.
Go ahead, buddy. No, go ahead.
So I was going to say, this is going to probably be the most challenging part of the case here, because we have to get into this gate, which thankfully opened up very nicely. But it's going to be a big bend to get there.
Guys, maybe an IMA catheter here.
So what's your preference on catheter here for trying to get into this gate?
If you're asking me, Ajit, I'd either use the IMA or a Cobra, just because that bend is going to be, and a glide wire, an angle glide, soft.
Just gently hold on to it.
Get the IVAs ready, guys. All right, here we go. Here it comes. Nice. Yeah. So we're going to drop this in there. There you go.
Leave that up there for now.
Yeah. I got it.
Got one.
All right, IMA. Also, do we have an Omni sauce just in case? Or
do we have a Sarah radial here?
Well, we have a what?
A Sarah radial catheter?
Sarah radial?
Or some reverse catheter?
Yeah, we have reverse curves. So we have the JB1. You want to use the JB1?
Yeah, let's just have it
get a
ready.
JB1 ready. We have a bunch of catheters. Don't worry.
So this is the part of the case for. Go ahead.
Ajit, so we have a protocol. Like we give it X number of minutes, and if the cannulating is a problem, then we do up and over. How much time do you give to cannulating this before you consider going up and over and snaring it?
Yeah, that's a good point. I think this one's going to be tough. So if we don't get into it soon, I might consider that. Because I still think we're.
Yeah, I think here you need a downward pointing catheter, even and then once you get it in, then you can pop it right back up.
Because we're still just so close to that bifurcation.
I need the angle.
Yeah, that's why, like maybe a Cobra or something.
What do you got there?
The wire and Cobra
Get us a Cobra catheter. I like a Cobra here. The other one we could try as well is I mean, it definitely. A little aggressive is a VTEC. You can get a VTEC up and over, and then flip it up and pop it right in if you want.
Yeah.
Has anybody tried
that's why I kind of like the
Motajime
catheter is another one. The Motajime catheter is another one we could try. Yeah. So I think Barry has the Cobra catheters. Barry, go to Barry's room and get a Cobra catheter.
Yeah, we're gonna.
Right there. What is that one right there? The glide cat.
The only thing. So if you were to go up and over, you'd fully deploy the graft. Is that what you do?
Get that one too.
Right, and then use your main.
Exactly. Yeah, I would. But I would give. I think you could get in from this side. I was just saying as a point of reference, because I'm not a big fan of eating up the clock doing a contra gate for a long period of time.
Nope,
you
the
have
other
a
one.
feel as you know what you can do and not do.
Just flip it up and over. Yeah. So look, we're going with a glide VTEC here. I know it's aggressive, but I think we'll be fine. We'll just get it into the distal and then flip it up, and it should be able to pop right up. I hope it's with a soft glide. If not, we'll do exactly what you said, Al. We'll just snare it.
I mean, I think with a Cobra or an IMA or something like that, you'll get in. It's not terrible. It's
No,
just,
I don't think the IMA's curve wasn't friendly. It didn't work. I know we did have an IMA in the beginning, right, guys? That was an IMA, right? It definitely wasn't good.
Yeah,
So I think we'll go ahead with this, pop it down, point it down into the contralateral, and then come back up. I think we just need to get a little purchase with the wire.
Yeah.
The only question is it going to form? Is the question? It'll form behind the graft, I think. We'll see.
Yeah, if you could put the Cobra right over your aortic bifurcation, it should be able to bounce off the wall and get in there.
Yep. This will bounce too. Let's see if you just need to form it. Yeah, just push it up. Yep. There you go. Not shove the wire forward. It should pop.
Can I get a torque on this? Yeah.
The Cobra? Yeah, Cobra. Give us the Cobra. Yeah, Cobra's fine. We got a Cobra here. If this might be too aggressive, we'll go with the Cobra if you want.
Yeah, let me give this a little. Yeah. Just so close to the bifurcation, it's.
Yeah.
It's too big. Yeah.
Yeah. Let me get the wire back here.
Yeah, just go with the Cobra.
Okay, we have a Cobra.
Yep, we got it ready. Yep.
Okay, I got it.
Yep, there you go.
In this case, though, I don't know if I would want to go up and over because I want to save that reconstraining mechanism just in case, you know?
Yeah. I think we'll get in. We just got to give it a few.
Yeah.
All right, so while we get the Cobra catheter, check an ACT, guys. So remember, all these kind of little things, check the ACT, make sure our ACT is good. Patient is doing great as we talked, and we're just going to go up and over.
Would you ever come from the arm if you're really struggling here and you couldn't go up and over?
No, very rarely I do that.
Torque, please. The other thing that can help is trying to rotate the gantry a little bit because this is like a 2D image of a 3D structure. So that's something that we'll try doing here soon. That looks promising. Unfortunately, it buckled out, but
yeah, you need to get a little bit more purchase.
I think that was it, though, so that means it's doable.
Yep, I just think you need positive on the wire, right, for him. On the catheter, I mean.
I'm going to move this down a little bit just so I can see everything that's
Watch
going on.
his face, yep. You're good.
Okay.
So I have a question here, guys. Like how I would try it is try to cannulate next to the graft into the native contralateral iliac, and then take the catheter down and then twist it up and come up. That's what I would probably try, because I think this is going to be very difficult for you to go around it and make it, because there is a little bit of room.
I wouldn't try around it. Gee, why don't you just try right at the bifurcation where you catheter right off the bottom? Because I think you can make that turn, because above
exactly.
below is going to be a pain in the ass.
Pull down now. Let's give it a little roadmap for a Jit. I think that'll help a lot too.
Correct. That's the curve you want, but drag it down.
Right there.
And you can get right in.
Yep. Here, let me give you a little roadmap. Ray, inject on the other side. Yep. Ready? Yep. Roadmap.
Roadmap on.
Let's just do a AP so we can really see the bifurcation.
There we go.
Now, with the graft in position where it is, can the sheath of the ipsilateral side be pulled back to give you some more room?
It is.
No, because then you're going to deploy it. Go ahead, Ray. Roadmap.
Ready?
Roadmap. Oops. Right.
There you go. See?
Okay. All right. Good.
You know what I'm saying? So you go underneath it and then come up.
Yeah. All right. Good. I have to be honest. I didn't realize we had that much room between the bifurcation. So this makes me feel a lot better, actually.
Yeah. So now you can go. Yep. And then point it up. That's all. So good.
Oh, is it already roadmap?
It should be roadmap, but it's okay. Okay, we gotta do it again. We'll do it again. Ray, let me give you that.
Oh, right, it's open.
There you go, guys.
But yeah, the other consideration in these small aortas is just making sure the contralateral gate opens, because that's something that could be
Let's fluoro.
Okay. Well,
Go
here you
ahead,
do
do
it
it.
from.
Don't move, sir.
Thankfully, in this case, it opened up nicely.
Yep. Perfect.
Beautiful.
Now we're just going to go up.
All right. Now I have no excuse.
No, this is not as easy as it looks, gang. Believe
Yeah.
me.
Well, I'll say this part either takes like 30 seconds or 30 minutes.
Oh, hopefully not 30. Liz is already hungry.
Me too.
Oh,
Take the catheter. Yeah.
Just doesn't want to form.
I think a catheter has to go
Yeah.
up.
Yeah.
There you go. So this is why I kind of like the SAS catheter. I think there you go. Now you're underneath. There you go. You're
That
in.
looks promising.
I think you're in. I think you're in.
Yeah.
So let's get the IVUS ready in a sec, gang. What?
All right. So this is an important step here is how do you confirm that you're in the gate? Thankfully, in this case, we don't. Yeah, I'll firm that. Thank you. In this case, we don't have a large aneurysm, so the wire really doesn't have anywhere else to go. But how do you like to confirm these, Alfio?
Yeah, I still do the traditional pigtail spin test, but if it's a small aorta, you have IVUS on the table. It's very easy to just run the IVUS.
I'll give you a Lunda quest. Hold on.
So Al,
let's do, actually pigtail. That's a good point.
The way I was trained when I used to do
You
these
hold the sheath?
was always IVUS. There was a live case I saw once when I was in this is back in the 90s when I was a fellow, and we used to have the old anchor graph, remember? And the gentleman, very talented guy, deployed it, did an IVUS, and actually wasn't in the contralateral gate and had to do a fem online, so it was not a very pretty sight. So since then, I've always been like, do the IVUS. So you guys actually spin the pigtail and feel comfortable?
Yeah, because in this case, especially in this case, it's probably okay because there's no room behind the graft. We're not fixing like a big aneurysm, so it's not going to spin.
So it won't spin freely.
Yeah, and even like if you had an aneurysm, if you spin it by the neck, it shouldn't spin either.
Spin.
So,
oh wow.
Usually that's a
281
fail-proof
test. Are we
okay
with that, guys? 281.
Yeah, I think that's good.
Okay, good.
The other thing that we can do is inflate a balloon, and you can see it kind of mushroom.
So IVUS is going in now?
No, she's taking the pigtail.
You want to do IVUS? I was going to do the pigtail first.
Oh, whatever you want. Let's do a pigtail.
We can do both. If,
we're going to do both.
Sure.
This way we'll do a randomized controlled trial. That's it. This way we'll see. So here we go. So again, it was you saw the techniques at home about how to be able to obviously cannulate this. Very tricky. The important points that Dr. Caraccio made about the gate and where it should face and so on and so forth. So I think these are nice techniques that we're learning, right? So I think it's important now to see whether this is a pigtail. It certainly looks good there. So let's go with a stiff wire here, guys, and then try to do the IVUS. Let's show the IVUS as well for teaching purposes. And then so we're still doing well with time. So as you can see, the pigtail spin test shows that the pigtail is definitely in the graft, at least by looking at it.
A small
There's a little tortuosity, so it's not really spinning. But there we go.
Well,
there we go.
It's definitely translating. But we're gonna put this up now, and now we're gonna go ahead and go with the IVUS. There you go. Excellent. All right. So now we're going to get so we have the regular 10 French or 9 French IVUS. What do we have?
Yeah, we have an 035.
035 IVUS here, and we obviously have a large sheath. So we're going to do a quick IVUS just to make sure we're in the gate. Ready to go, IVUS, guys? We're going to go in a second. So ACT is 281. Would anybody give more heparin? You guys happy with that?
Personally, I'm happy with that.
Around 250.
Yeah. Okay, so we're good. We're good at 281.
It's a perfect range.
Now we're going to go with the IVUS.
I do like to reverse at the end, though, especially with the access.
100%.
Okay. We're bringing up the IVUS here.
Can we have the IVUS? Yeah.
IVUS image coming up.
Just fluoro.
Yep, off fluoro.
Off fluoro?
Yeah. So what we're going to do is switch on the screen here. Alfio can see it, but we can't see it here. Yeah, there we go. Okay, now go. Fluoro, and let's go with the IVUS. All right.
All right, you can take the
IVUS. Go up.
Okay.
Yeah.
So IVUS is going up. Soft part of the wire, guys, but that's okay, I guess. Good. Excellent. Thank you.
Okay, so that's IVUS. We're in the common iliac at this point. And so we're about to enter the gate. Let's see.
The 10 French gate is not a...
Yeah, we're catching it a little bit here.
Yeah.
Maybe pull on the soft part of the wire?
Yeah.
That may allow it to unbias out.
Hmm.
Yeah, probably pull
You
it
just
back.
switched. You switched up for stiff wire already.
Yeah.
Yeah.
Oh, it might be. Might be.
Well,
Just
But you know
catching the
what,
end because of
guys?
the
You
angle.
have a 12 French anyhow. You just watch the 12 French go up, and then you can run the IVUS through before you put the device up because it'll tape. The 12 French tapers nicely. You're going to need it for the Contra limb anyway.
That's a good point.
Yeah, I
So
don't think
push
it's
the
gonna work.
sheath up. I agree with that.
Okay.
All right. So get us a
I'll walk this
dilator,
out.
guys.
Take the IVUS out.
Yep. Actually, sorry. The other thing we can do, well, we have the, we can actually. I was gonna say we can measure the hypogastric length, but we can't. All right, so yeah, take this
Yep.
out.
Let's take it out, and then let's go with the dilator. That's a good point, Al. Use
Yeah,
everything we have
at
on
least
the
the
table.
12 and like Ajit said on the way back with the 12 in, you could just shoot it and you have your markings. You can kill two birds with one stone.
All right. So we are now going with the dilator.
Mm-hmm.
So you want to bring the sheath into the limb then, and then put the IVUS back up?
Yeah,
Is that
because
what yeah.
correct. Because the tip is so tapered, it'll slide right through there.
Yeah,
without
good
causing harm.
Mm-hmm.
Obviously, you don't want. This is not a case you want to telescope because you're right at the renal. So as long
Right.
as the stylet goes through and the sheath goes through, then you can put your IVUS up and then pull your sheath back and confirm with the IVUS that you're not behind it.
Very,
Yeah,
very
sure.
nice. Very nice technique.
Okay.
So that's a great technique, and now we're going to
Walk
do
this
the
up.
IVUS, and then we'll deploy it. So Al, a little bit about post procedure. Obviously, this is not an aortic aneurysm, although we're dealing with it as such because of the technical issues. Surveillance wise,
IVUS
what other
again?
things do you do? I mean, do you survey them the same way? What are the thoughts?
The case here, you all did such a good job at embolizing that internal. You do something like this that there's no real high endo leak rate possible, really, because you covered so much above in the contralateral side and into the external. I would do it with just duplex, to be honest with you. Maybe in a few years do a CTA just for the sake of confirming where the hardware is all sitting.
Yeah.
But I think a duplex would be plenty.
And what are the longevity of these grafts? I mean, we're talking about obviously a young man here, who's got this problem, and now we're fixing him. What are the chances of degeneration of these grafts? Tears of the fabric, so on and so forth.
Very, very unlikely. In other words, here in terms of if you land in the external for a few centimeters and it's sized appropriately and you have the entire aorta rely on the other side's common iliac is healthy.
Yeah, let's
I
do
wanted the Lunderquist.
Let's do a Lunderquist.
I think it'll last a lifetime.
Push it up a little bit more then.
Got it. Well, that's great because now you can see here we're now
get a
going to do a quick
Lunderquist.
pullback on the IVUS. We've already shown that we're within the
Lunderquist.
graft. So now what do you need?
Just a
Lunderquist
Lunderquist
wire, guys.
We're gonna go even stiffer
so
wire.
now we're going to get the contralateral limb Lunderquist wire, and then we're going to go ahead and so we've now confirmed our position, so we don't need to do any more IVUS, and now we're going to go ahead and get the stiff wire up.
Or curved.
Anticoagulation wise, Al, in terms of aspirin, Plavix, what do you guys do for these grafts? Obviously, cardiovascular risk factor modification is very, very important, but beyond that, in terms of anything specific for the graft.
No, I mean, most people arrive already on the statins and and an antiplatelet, and if they're not, that's what we put them on, just because the prevalence of peripheral, what really gets categorized as peripheral arterial disease, sort of warrants a statin and an aspirin, but that's more medical management. The graft itself.
Yeah, I don't want to make the sheet.
So the graft itself does not need antiplatelet therapy because of the high flow states?
Then go.
Yeah, as a general rule, I think so. I mean, the data, it's not like the data shows a patency difference of that. I think it's more of medical management, but anytime you have a graft with that kind of surface, I just feel more comfortable having them on something very operative.
So we're just going to pull the IVUS back now. Ready to go live, guys?
We're live. Start live.
Yep, go.
So we're in the main body right now. So that's what you're seeing here. You're going to see the bifurcation right there. And thankfully, it looks like our IVUS is right in the middle of that stent graft. So I think we're perfect here.
Yep.
And then as you go down, that will be the common iliac. And then the bifurcation might be a little bit lower, but I think that looks good. So we have our stiff wire. So I'm actually going to put the IVUS back up and use it like a pigtail with the markers, so we can figure out what length limb we need now to land it at the hypogastric.
Yep. So let's walk the sheet back a little bit. Take a shot.
Do you know roughly, Sarah, what length we were looking at? All right, so we got to go back quite a bit. Let's see, 1, 2, 3, 4, 5, 6. All right, so let's take a picture there.
For those at home, obviously we've coiled off one
hypogastric. Yeah,
hypogastric.
it's better to take
We don't want to lose the other hypogastric. So what we're doing is we're trying to see how to land this to get a seal, contralateral seal, and make sure that without closing off the hypogastric. So you've seen a lot of different techniques on how to do this, and now we're going to take a picture, and the picture is going to tell us where there it is. Beautiful.
Right, so that's pretty easy to see. So we're going to mark it on the screen, and then
so now we know where it is, and then we're going to do a roadmap, and we're going to take care of it.
I'm just going to take it. 9.
9.
Just do a. I don't think we have plenty of length, so maybe 9.5. I don't want to. Yeah.
Yep.
Yeah, it's not worth taking the risk here because we already embolized the hypogastric.
Yep.
So on this side, the iliac measures about 13 in diameter. So we're using a 16 millimeter limb.
So how do you size that, guys? 13 to 16. It sounds awfully large in our ears. How do you decide that?
Yeah, no, that's a good point. I mean, they only come in certain diameters, but around 20% is usually, will be fine. If you have to go a little bit higher, especially if we're talking about a millimeter, it's usually okay.
Yeah.
So is there any worry about thrombosis because of infolding, things like that we know with the standard Viabond stents? Anything like that we need to worry about?
Got worry. I think the patency, and Alfio, correct me if I'm wrong, but the patency for these iliac limbs is very, very good. I think things that can make it a little worse is if you have poor outflow. So like if you have a very diseased common femoral, profunda, occluded SFA, common femoral, if you potentially have to extend into the external, but in this case, it's not such a big deal on the right side because it's such a robust vessel.
Beautiful.
But in general, these do very, very well over time.
Alfio, anything else on your end in terms of patency?
Yeah, G's totally correct. I mean, the overall rate used to be about 4 or 5%. Now it's probably down to 3%. All the variables he said are the risk factors. A subgroup like this that has straightforward common iliac on this side should be very, very low. I always look at the hardware when we're done to make sure there's no crimp of the stents in any way. Do like a kind of a spin, but without the die, just to see the metal isn't pinched off anywhere.
Right.
And it generally should not be a problem. I would focus on the external on the right because it does take that turn out of the pelvis, and the collaterals are lost on that side now. But it should be all comers less than 5%.
Contrast. I just want to take one picture.
Got it.
Are we able to shoot through the sheath once this is in, or no? Yeah, so I'm just going to take one more picture just because.
Want to roadmap it?
Yeah, maybe we'll even roadmap it, but okay.
Just floor. Yep, the left one. Yep. Inject. There you go. Okay. Perfect.
Yep, marker still looks good.
All right.
All right, so we're advancing the limb here. We're going to be careful.
Yeah. Now, by the book here, it's interesting.
To change the
about this.
No, because
gentlemen, so by the book here, theoretically, you should be putting this sheath back into the graft rather than just going up with it.
My hair is not.
I don't do that all the time either. I just kind of go bare. But the only reason being is remember that little maneuver at the beginning when we pushed the graft up.
Yeah.
Theoretically, can you get a little bit of a nudge that you end up on the renals? I guess theoretically it's possible.
Yeah. So,
I see. So you don't want to by mistake push it up.
Yeah. No, that's a good point. Yeah, you definitely called me out on that, but but yeah, I was very careful. When I advanced it. If I had any resistance, I would have. No, and truthfully, I would have. If I had any resistance, I wouldn't have done it. I would have pulled it out, put the dilator back in, and then put the sheath in. So here we're lining up the top of the limb here with the top of the marker. I'm pretty happy with that. Roadmap? Everyone happy?
Yep, off roadmap.
Yeah,
off roadmap now. We have our marker.
Okay, good.
Good.
So we're gonna
beautiful
gently deploy it.
So does this jump forward at all, guys, or no?
No, this actually deploys pretty accurately, I think. And
sort of like
I didn't even have to move it, and it looks good. You can try to elongate it a tiny bit if you need to, but I think I think it looks okay.
It looks great.
Yeah, yep, that's gonna be fine. Can you hold the sheath here?
Excellent.
So that's that one. So now we gotta finish the other side and the main body. I do want to take one more run just to make sure the renals are okay before we fully commit. If everyone's on board, and then we'll deploy and we'll be done here soon. Pigtail on this side first.
Yeah.
So we're just gonna go with the renal. What happened to our pressure, guys? Just in case. So, something's going on with our pressure. Flush everything, please.
Here.
Let me just make sure
Yeah,
our
of course.
pressures are
Here
good.
and there.
Yep. Give me a 10 cc syringe, please.
Ray, fix the sheet. The other, yeah.
Okay. Just gonna rotate
Sorry
this
about
here.
that. Just want to make sure that we don't have any clots. All right.
Okay.
Mm-hmm. So my pressure is still terrible. So where is that line coming from, Damien?
Mhm.
Is it from the
Can I pull this
opposite
far?
side? From the
Okay.
right?
Can I get contrast?
Huh.
Mm-hmm.
Interesting.
It's very hot. What is it?
No, move it to the left.
Got it. There you go.
Here you go, some contrast.
I want to do a.
Thank you.
Yep, we got a pressure on the left, so there might be some kink of some sort or something going on. All right, let's take a picture.
Okay, we're ready to take a picture.
Yep, DSA.
Hold on, hold on.
Oh, we got it now. Good pressure now. All right. Yep, thank you.
Yeah.
Okay. All right,
Beautiful.
beautiful. All right, looks good. So
All
I
right.
think we're going to commit to this now.
Yep.
So we twist. So
All
next
right,
part,
everybody focus on his hands, please, for me.
So this is the next part where we twist this handle and we pull it off. And this will remove the constraining wires for the graft. So that looks good. We have to pull our sheath back, right? So now the next thing I'm going to do on the right side is pull the sheath back
On sheets.
past the iliac limb. So now it's distal to it. And then the last thing will be releasing the distal limb, right? So for that, it's this mechanism right here. Again, it's just pulling it out just like a Viabon. And you'll see the sheath limb on the right side fully deploy.
And then you have to unsheath
And
the
then we're
rest.
done. So now we just have to do the iliac limb on the right side and we'll be all done. So I'm gonna, do you have the sheath here?
Yep. And just
So we should watch this come back, which I
Yeah.
did. Make sure it doesn't catch
Mhm.
anything. Looks good. Can you walk that out?
Mm-hmm.
I'm gonna get ready for oblique here. We'll need the pigtail next because we'll need to.
need another. We need another pigtail, guys, or same one or whatever.
We can just exchange it out, I guess.
Yep.
Any sort of wire on the side will be good. Watch your knees.
We
though.
have another pigtail anyway.
So the other thing is the
You use
hypogastric.
the other pigtail, guys. We have another pigtail.
Oh, beautiful. Or anything with markers, even the IVUS fork.
No, we've got a pigtail with markers here, so. All right, so I guess we're about 3/4 of the way done, God willing, and then another 5 minutes or so. I'm not going to show the balloon angioplasty. Once we do this, we'll just do it offline. This way Alfio can get back to his day, and we can close this case up. So we are now going to go ahead and measure this limb, obviously the contralateral. So why is this important, Al? In terms of why not just cover all the way to the common femoral? Why does it make a difference or does it not make a difference? Obviously not covering the common femoral, but why not get to the common femoral?
Yeah, because I'm not sure it makes a difference, BK. You know what? It'd be extra device, and sometimes if there's a question of a piece, you'd have to go further down, or if there's a flap further down,
Yeah.
I always extend down to cover any flap. So if there's a bad iliac, then yes, because you'd hate to leave a flap sitting behind. But if it's straightforward, all you need is a couple of CMs, and that's all you need.
Got it.
Yeah, the other thing is there was a little bend, I think, in the proximal external, so it might be worthwhile trying to go past it. Let's see what it looks like. Probably straightened out with our wire, but
Yeah, you see that? They got that little bend up front too.
yeah. Actually, I think we can land it just distal. I don't think we have to go all the way down there.
Yeah, just
Yeah,
there.
right there.
You wouldn't want to cover that bend that's been straightened out by the wire all the way down by the bottom left.
No, I'm thinking we can land it above the bend because there's at least what, let's see, 1, 2, 3 centimeters, 4 centimeters above it. So why land it right at the bend? What are your thoughts? I think maybe landing it right above it is probably sufficient.
Yeah, generally, I mean, if you think it's accordioning it and it's from the accordioning, I don't really focus on that too much. If it's a real bend, I like staying out of the bends. But here, I agree with you, Jeet. I think it looks just maybe about 3 CMs into the external should do it.
Yep.
So Sarah, what length were we getting here?
You could use a 12 or 14. If you use a 14,
So what's the length from the gate?
from the gate it's 14. 0, 1, 2,
And what's the one length above that? What's the smaller?
Small 12
I see.
or that.
Mm.
Probably 14 is fine.
Mm.
But if you want to go up to the gate, but 12 is
So what is the advantage of going up to the gate versus not?
It just maximizes your overlap, so that prevents like a leak between the stent grafts. Here
Got
we
it.
have plenty of centimeters. So I'm just trying to debate whether it's worth trying to really nail it, but I think 14 is
14 's
probably
good.
okay. It's going to land where we want it.
Okay,
With
let's do it.
14.
14 by 14. 14 and a half by 14.
Can you hold the sheath?
We need a wire, guys. Lunderquist
We
again.
have it. It's in there. Hold the sheet. Yeah.
ACT going in the back of the table, gang.
The other nice thing is if you know, you have the ability with these limbs to kind of foreshorten or lengthen them a little bit. So you know, you have some wiggle room as well.
So Al, you were talking about the bend. Why are you concerned about a bend? Is it a natural kink in the
Should we try
graft
the
that you're
last
worried
one?
about?
Actually, I
Yeah,
see it there.
just sometimes if there's a bend, it really, these conform very well, so it really shouldn't be an issue. But, you know, theoretically at a bend, it may crimp it off. And
Yeah,
if
no
it's crimped
space.
off, it's a potential focus of, you know, of potentially impinging on the flow of that limb.
Got it.
And
All
the
right.
reason being is it's been known, you know, if you lose a limb in the common iliac, they usually don't have symptoms. But if you lose a limb in the external iliac because you lost that hypo, they're usually very symptomatic, and you need to do something about it.
Mm-hmm.
And actually, you can even see on this last run, I don't know if you can see up there, but you can see it leaking around the iliac limb.
Yeah, I can see it.
And I forget what size this is, but it's you know, I don't think sealing up there would have been durable. I think it would have leaked right through it
Yeah,
like
this is what I was
this.
saying. If you look now, right, the device, you need 5.5, let's say maybe 6 cms for a branch device. You could have
Right.
landed your branch in the aneurysm and kind of ignored the origin of the common. You probably could have branched this if you wanted to. It would have been a lot of work, but it may have been something you could have done.
So
Yeah.
now we're gonna go up now. As far as ballooning it, would ballooning it reduce that endo leak that we're seeing right there? I think it would, right? You're obviously gonna balloon it with a large balloon now, and that should definitely seal that up.
So this looks perfect. Sarah, what do you think?
Yeah,
Just
and
gotta
actually,
confirm.
PK, on your comment, you know, when you land in the external, they're very durable because the externals
little
don't
bit higher
usually,
up.
if you appropriately deploy a few cms into the external,
Right.
externals don't
That's good, right?
degenerate into aneurysm. So it's a very durable seal.
That looks really good.
I
Yep,
hope so,
like
because I already deployed it.
that.
Too late.
Now, so what I'm doing here is I'm actually putting a tiny bit of forward tension on the limb because it looks like it's going past our marker. So
actually
that
it's
way it
before
foreshortens a
it.
tiny bit,
Yeah.
which we don't need much, but
It's just
yeah.
right
That's
up there.
perfect.
All right.
Nice.
Looks beautiful.
All right.
Okay.
So
Leave the
now
sheet.
now we've deployed both limbs. We're gonna obviously
Balloon.
we're gonna do an IVUS, or do you want to just balloon it now? How do you guys
let's-
Take a
proceed?
picture.
I think because we're treating an aneurysm, we should balloon.
Yep, I agree.
Pretty much
So how do you
routinely
guys
balloon.
size the balloon in a normal aorta?
We have a compliant, right?
So any compliant balloon works, or anything in particular, guys, that you like better than the other?
For me personally, I like the compliant balloon. So Gore has their own one. There's also Reliant Coda, so anything like that, just to kind of iron out the graft, make sure it's well opposed to the wall.
So, but how do you size it? Do you size it just
Oh.
by balloon sizing? You know,
I just like by
Angio.
by fluoroscopy, I
Mhm.
just make sure it's like opposing the wall and kind of
got it.
watermelling a little bit.
And is there a chance of the graft foreshortening in any way in the renals, or going long in the renals in any way?
No, I don't think so. I think it's gonna stay pretty much the same size.
And
The
do you,
one-
and do you kiss balloon the gate?
No, but I'm definitely less aggressive about ballooning at that point. But
So the radial strength is enough.
yeah, because it's
over
a
there.
self-expanding stent.
Got it. You're not going to crush it. Okay,
exactly.
excellent.
And then the other thing to just be careful when you're ballooning proximally, because you know the last thing you want to do is cause like some sort of dissection.
Antegrade
Look
dissection.
over
Yeah.
for a second.
Or retrograde, is it?
Yeah.
No, it's antegrade. No, it's retrograde.
Retrograde, yeah.
Yeah.
So I'm actually going to stay a tiny bit within the graft because I don't see we have such a long neck. There's no reason to be aggressive here.
Yep.
And so just you want to see it kind of open a little bit, go a little bit higher.
Mm-hmm. Yeah, I'm gonna help you have.
You have more?
Just hold the wire for you.
Mm-hmm.
There you go.
And so you just want to see it pose the walls and then deflate. Really don't need to be too aggressive.
I'll help you.
So no real science to this other than just a feel, huh? because you're not looking to see a certain atmosphere or a certain balloon size.
Correct.
You're sort of
Yep,
just
that's
feeling
good.
it just to make sure that it's
Yeah,
good.
I'll hold it. You do.
Correct. And then the most important thing is the proximal and distal,
Right.
and the overlap zones for the stents. So now we're going to go back into the
Right.
into
Well,
where
this
our
is where
iliac limbs.
intuitively I would have thought you would crush the other limb. I guess you don't.
Yeah, no, that's a good point. Go ahead.
It can happen. It actually can happen. So even though that's self-expanding, PK, sometimes in terms of kissing balloons, if that's an angulation point and you open one side, it can impinge on the other, and they don't always self-expand. So in a straight case like this, should be okay. But there are times when you balloon one side and you see the other side flatten out and not re-expand.
Yeah.
So would you re-IVUS, Al, or would, I mean, if you suspect it, or do you re-IVUS all of these just to make sure?
Yeah, I don't IVUS, but it's a great idea. If you have it, it's readily available. What I do is I kind of do a spin and look at the, like a full 90 to 90 degree to watch the hardware and make sure it's not pinched off.
Right. Got it.
IVUS is more accurate, so if you have the
Just really
IVUS
hold it
there
here.
on the table, it's easy enough to run it through, make sure everything's open.
Yeah, we'll
But,
definitely we'll do the IVUS before we close offline. But I just want to ask for the audience, obviously, the questions that they need.
Your sheath.
It's more thorough. It's, you want to, my philosophy with this is when you walk out of this case, you want to make sure that there was nothing that was unaddressed, because if
exactly.
Do we have
and half of them will end up with a leak,
or something?
in terms of type 2s and all that kind of thing. In this case, probably not, but
yeah.
If they end up with a leak, you want to know in your mind that you've done everything you could to address any potential sources.
You want to do a pigtail angio here?
Yeah, so we're going to put the pigtail on the right side now, and then on the left side, we're just going to balloon the iliac portion of the limb, and then we'll take a picture, make sure everything's okay, and hopefully be done. The other important thing here is just making sure the limbs aren't crushed, especially in a small aorta, things like that.
Well, yeah, that's why I was thinking about kissing balloons,
Yeah, so that's
you do two kissing balloons, you ensure they don't crush, or else you go one after the other. But, listen, I think you can probably put what did the iliacs measure at, guys? You can probably put.
It was around 12, I want to say.
So 12, so you can put 2 10s, and kiss it out if you wanted 2 11s, and at least you expand it. But it's completely up to you guys.
Yeah, I guess we'll take a picture and then maybe decide.
Then we decide.
Yeah. But I think the iliacs were bigger than the largest VBX, which is one of the reasons why we also didn't consider just doing an iliac stent graft. Other important thing is to make sure your balloon tracks well through the end of the limbs, doesn't catch anything.
Or push it up, yeah.
Okay, you can go up there.
Let's go up here. So we're just going to go up to profile again.
And then can you load the pigtail on the right side? Good. I'm going to bring it up a tiny bit.
Yeah, got to go up a little bit. Yeah.
Just very gently. Again, we have so much overlap and so much seal zone the way that we plan this out that you don't have to be very aggressive here. Just get that sheath.
I think he's got to go, you know what.
Oh, almost done here.
Almost done.
Okay, I'll go up again. Now, the other thing is we may not, sometimes the sheaths can be occlusive. So when we do this next run, we may not see one of the iliac limbs potentially fill. In that case, we'd have to aspirate through the sheath. Yep, one more time.
Oh, okay.
That's another thing to consider. It may
What's
not
our
be.
last ACT, gang?
Yeah, that's good.
Okay.
Now, I have a question. Do you guys remove your stiff wires when you do your final runs, or do you leave it in? What's your kind of algorithm for that?
I mean, what I would do is I would remove the wires. I mean, I want to see the conformity of the graft. I don't know. What do you think, Al?
I agree with you, PK. I mean, you have a pigtail on one side, the other side you switch out for a catheter, this way you have ready access in case you have to go back.
Right.
But it removes all potential kinks. Again, same with the theory. You want to walk out knowing everything look perfect before you walk.
So we're just gonna go put a soft catheter up the other side, guys. Just put like a vert-tip catheter up.
Yeah, any catheter, and we'll pull that wire.
And then we'll just do this. This should be the final shot. For those at home, I think we've covered, pretty much, all the nuances of a iliac aneurysm case, and probably even of a regular aneurysm case. Obviously, this iliac aneurysm is something that was very large, really behaved like an aortic aneurysm involving the distal aorta. And we talked about all the different nuances that go with it, including equipment sizing, techniques, different approaches on how you can deal with it.
Mm-hmm.
So yeah,
Catheter?
switch out the white guys for the soft catheter. So what we're going to do now is we're going to take a final. Can you? Yeah, put a catheter up.
Yeah,
What we're going to do
right
is
now.
take a final shot here, and then we're going to say goodbye to you guys. We'll stay online.
Yeah.
We're going to go ahead, IVUS the two limbs. Make sure there's no crush of the limbs, and then after that, we're just going to do our pre-closes, and we'll be done. We talked about anticoagulation of this patient and surveillance, and I don't think any of that is going to change. You might want to aspirate, Ray, on the right side. You might want to aspirate with a 20 cc as he injects, so there's flow. So you can see the flow in the limb.
The injections through this.
Oh, then on the other side.
Are we ready?
Ready?
Yeah.
Let's see.
All right.
All right. No, let's see.
No, just the pigtail, hopefully.
All right. Well, we have flow. It's a big
Beautiful.
vessel. So that's great. I think it looks good. What do you think, Al?
Yeah, very nicely done, everyone. You did a great job on this.
Al, are you worried about that distal aorta right there? Do you see the little, I'm just curious whether you guys would iron that out right at the distal aorta, a little bit of filling defect right there, or you just think it's a kink or a turn on the left of the screen? You see that? Maybe I'm just being a little too much.
You mean right below the
You
renal?
mean
Yes.
by the flow divider right above the
Yeah,
two
right
limbs?
above. Yeah, exactly. Would you
Yeah, it
iron that
doesn't look
out?
terrible, but if there's any doubt, I would balloon it. Why take a chance? Because that's right above a limb. Because if there is a kink there and it's impinging on one of the limbs, you don't want that. So it may be worth it. And in particular now, when you talk about the kissing balloons, a good time to just put balloons, if you can do from both sides, up across that, and this way it irons it all out in unison. This way it doesn't transmit it up or down.
Yeah, I'm just saying we're in here anyway. We took the morning to take care of this patient together. So yeah, I think we'll do that. So anyway, we're going to sign off here, Al. Thank you so much for your time. Can't appreciate your time and your expertise, and thanks a lot. I really appreciate it. Again, thanks Dr. Rao for taking his time to come and share his expertise with us, and obviously our entire team at Sinai. So thank you, Roman, if you could sign off.
All right, guys. Well, everyone,
All right, what do you want to do, brother?
thank you very much for joining us today
Yeah.
for our very interesting live case today. We look forward to welcoming you next month on Wednesday, March 29th. All right, we will see you next month. Enjoy the rest of the day.